I'm Wayne Skinner, and I'm a Deputy Clinical Director in the Ambulatory Care and Structured Treatment Program at CAMH. There's huge potential, I think, when we think family, and I think there are huge problems right now. There's a big gap between, I think, the way things could be and the way things are. So I think it's one of the areas that we can grow and develop in as we look at developing better mental health and addiction services, actually. The default in our care actually seems to be to exclude the family. And I think this is one of the last kind of frontiers of stigma, that if we really want to be normal health care, when you have a physical health problem and you go to the hospital, you're admitted, people expect the family to come. They want to know who they are, they make an effort, they're welcoming, they're outreaching. And that is not the default in mental health and addiction treatment. The tendency is to presume that they're going to be excluded. And my view of a better space would be, the default would be to expect that there would be family and concerned others who would want to be involved in somebody's care, and that would be important to the patient, and that we should want to know about that and we should want to facilitate it. That's just for the episode of care. The other thing is on the after side of care, we know that people's best outcomes come from social support. So if we're not actively building social support for people as part of the helping process, we're leaving it to that person to somehow do this magic, right? And we're leaving a lot of people disconnected, maybe not even understanding the nature of the illness and the treatment. This is another thing that happens in regular physical health care. If you need medication, you need follow-up, you've got special accommodations that need to be made, they make sure that the concerned family members get oriented to that, right? They give them education, they'll talk to them even right at the bedside. So the presumption in regular health care is the family needs to be involved, should be involved. And we need to allow that a person might want to exclude somebody or maybe not have anybody involved in their care, but we shouldn't make that the default. I think really we should be welcoming of families. We should realize that if a crisis has happened in a family, requires somebody to be in a hospital, that's activating for anybody. This shouldn't be any more of a problem for us to understand than somebody has a heart attack. The family would rush to the hospital. Someone is admitted because of a psychiatric crisis, it would be a good thing that people would show and want to be helpful and understand that. And there's a great opportunity if we had this different frame to coach people, to let them know, maybe this person doesn't want to see anybody right now, they haven't given permission, or yes, actually, you could help us with these things. We could also learn about this person, in terms of what are some of their issues and special needs. How can we be more effective actually in making their stay here successful, because we're understanding kind of what their issues and needs are. At the time of making the appointment, we could say, you're welcome to bring somebody along, who you would like to have with you. In the interview, you could say, would you be happy if we brought in this person? Is there anything you wouldn't want us to talk about, or what would you want them to know? So you would actually, from the get-go, actually be building this to include other people, to work with other people. Sometimes, because of the nature of these problems, it's difficult for clients even to remember appointments or what was said. And so having other people there who can actually remember that, note when the follow-up appointment is, the idea that there are gaps between appointments, that people have to go back home and they have to sometimes wait for things, right? And so having family mobilized around what would be supportive and helpful and just have them in the loop would give us so many more advantages, I think, in care. Again, this needs to be client-centered. I'm not, so you'd be working with your client rather than foisting this upon them. But it would be really different, and we have so much to learn, I think, from regular health care, because they do this really well. Every patient has a right to exclude people from their care, and so I don't want anybody to know anything about what's happening to me. But if a family member showed up and they would want information about about the nature of certain illnesses or about your services, you can give a lot of helpful information to people without actually disclosing about somebody's particular care issues and program of care. So you could work with these individuals. In fact, many times you have family members who are wanting to be involved, and perhaps the patient doesn't want care from the service, so they ought to be allowed to be clients themselves. So, and there's evidence actually that you can do intervention, or therapeutic activity, if you will, through a family member. So often what people find is that when they change some of their own behaviors towards an ill family member, that actually that affects the process and it affects what goes on. The other thing is, I think, on the other side of care, when people are completing care, I think it's so important that we appreciate how vital social support is. And that needs to start with the family. If you're lucky enough to have a family, because there are many people actually who are our clients who don't have these resources anymore. They've kind of burnt them out, or they've used them up, or they've never had family support to start with. It's often a big factor in people not being well, right? That they've not been well supported as they've gone through their lives and the like. So their illness is sometimes rooted in those dimensions. Probably the most significant predictor of ongoing recovery and reduced risk of relapse is actually family and social support in a broader sense. And we need to think of families not just as like the biological family, but we need to think about who are the familiars, if you will, in this person's life. Who are the people for whom the client feels a positive connection? There's some evidence that just involving one other person, like you don't have to deal with the big crowd even. Like, get the client to tell you who's the most supportive person to you, who's the person who's going to be most important for you in going forward and dealing with your recovery. Can we invite that person in? And when that happens, actually, that makes a significant difference in outcomes. We know this certainly in the addictions area and in the mental health area as well. So there's strong evidence for doing this as well. It's not just a good idea because it sounds good, but it's a good idea because it's an effective thing to do in helping people with recovery.